session. Dr. Akasaka is going to talk about the benefits of imaging. How do I select patients for OCT to improve clinical outcomes?
Okay. Thank you, Mr. Chairman, and dear delegated discussant, and also the ladies and gentlemen. It's my great honor and pleasure to be here today, and also that I appreciate the kind invitation. Could you show my slide?
Can we get
the slides here?
Can we get the slides up on the screen, please?
I can see my slide, but not on the screen.
Yeah. Can you project his slides? I'm seeing them on this screen, but not on the main screen.
I can see.
There you
okay,
go.
Thank you. I appreciate, right? This is my disclosure. As you know, this is an OCT principle. OCT is very similar to the IBUS. Yes. We use an infrared light instead of ultrasound, and this light goes here to one goes to the vessel and one goes to the difference, and then make a coherence and get an image. And this is OCT. How to get an image by OCT? At the time of angio, you insert the wire and then insert the fiber, and then during angiography you can get an image 5 centimeter or 7.5 centimeter per 2 seconds or 3 seconds. It's quite easy to obtain the image, as you know very well. And then this is one of the examples. As you know, there are 3 markers in OCT: the distal tip, and second is a lens marker, and there are some another marker, 5 centimeter proximal to the lens marker. It is very important because in this case, target region is an ulceration, and the other region can be identified in the proximal RCA. If you decide the 5 centimeter pullback, it is not enough to identify the proximal region. Then we decide 7.5 centimeter pullback, and during angiography we get the clear image. And initially you can identify the cross-sectional image and also the longitudinal image at the same time. Here you can identify the ulceration. And if you put on the 3D reconstruction, you can get 3D image within a few seconds. And then further development can be demonstrated today. We can use the stent reconstruction, and also this is one of the examples here. I moved the cursor to the distal portion, and you can identify the position of this is an angio co-registration. You can identify cursor position by this marker on angiography at the same time. This is angio co-registration. It is very useful in the daily clinical practice. And then we can demonstrate the stent condition as shown in this slide. You can demonstrate the stent and also the apposition condition by the color. Red color demonstrates more than 400 micron incomplete apposition, and yellow color demonstrates 200 micron incomplete apposition. You can check the incomplete apposition automatically by using this software. It's quite easy. Based on this development, our practice a little bit changed compared to its previous condition. As you know, in Japan, we always use an guided imaging at the time of PCI. Previously, IBUS-guided PCI is more than 90%, but after development of OCT, as shown in this slide, in our institution, only 20 to 30% use an IBUS guide in case with an left main orifice and RCA orifice and CTO cases. Almost all regions except for CTO or other region, we use an OCT guide, nearly 70 to 80%. How to decide the landing portion? This is a stable effort angina case. Initially, we speculate a region length nearly 26 millimeter. This is a proximal landing zone. You can identify the three vessel normal-looking area. This might be the ideal. However, in the distal portion, you can identify the lipid-rich plaque from 6 to 11 o'clock. So nearly 2-quadrant lipid may increase the H stenosis. Then we try to identify the much better portion within 5 millimeter. This might be the much more stable. You can identify calcium and some plaque, fibrous plaque. This might be ideal. Then the stent length should be 28. And then if you put a stent, you can get a good result. Why we avoid the lipidic plaque as a landing zone? As shown in the right-hand side, if we put a stent at the site of lipidic plaque, more than 2 quadrant especially, the stenosis rate is significantly higher than the other plaque, as shown in this slide, fibrous compared with fibrous or fibrous calcific or normal. So you have to decide the landing zone by using OCT. This is much more detailed analysis. The lipidic plaque more than 2 quadrant makes much higher stenosis rate, as shown in this slide, even in proximal or distal. And this is a multivariate logistic regression analysis. There are a lot of mechanisms of the stenosis. However, the lipid-rich plaque is the most predictive value for speculate the stenosis. Also, the minimum lumen area is another factor to predict stenosis, as shown in this slide. This is another case. You can identify the percent diameter stenosis very easily, and then we decide the reference site, and then put a stent. You can easily identify the result, and still in this case, the area stenosis is 21, and it is not enough. So you try to use bigger balloon and higher pressure in this case. So we try to get an MLA more than 90% of the average reference lumen area, but sometimes in the real clinical practice, it might be very difficult, especially in case with a complex region. There are lots of recommendations of OCT use. There are lots of expert consensus document as shown in this slide. And this is one of the examples of the single center retrospective study. If you use the OCT compared with angio guide, you can reduce death or cardiac death or other MACE compared with an angio guide as shown in this slide. And why we can expect this result? This is one of the explanations. Compared with actual phantom model, OCT is very accurate in the measurement compared with other modality. I was always overestimate, and in real practice, I was also overestimate compared with OCT, and QCA underestimate compared with OCT as shown in this slide. And also the reproducibility is very nice in OCT compared with IBUS based on this report. And recent development, as I already explained to you, we can easily identify incomplete apposition by color representation. And the red color is more than 400 micron, this incomplete apposition. So if you find these findings, you try to dilate proximal site using a bigger balloon or higher pressure, as you may expect. And because if the incomplete apposition distance is more than 350 micron, you may have an incomplete apposition long after stent deployment. So the incomplete stent apposition distance is less than 305 micron in years. It will disappear 6 months or 8 months after follow-up. That is enough. And we already demonstrate the OCT-guided PCI is non-inferiority of the OCT-guided PCI compared with IBUS in opinion trial in European Heart Journal. This is a protocol. We divided a one-to-one OCT guide and IVAS guide. We follow up the 1-year clinical result, and we succeed to demonstrate the similar target vessel failure, and secondary endpoint is very similar. So OCT guided PCI is non-inferiority to IVAS guide. And another study is Illuminen 3, as you may know very well. Based on this data, they succeed to demonstrate non-inferiority of OCT compared with an IVAS guided. However, they failed to demonstrate the superiority of OCT compared with angio guide. Then they tried to demonstrate the superiority of OCT guide compared with angio guide in Illuminen 4. The study population should be much more greater than the Illuminen 3. This is the protocol of Illuminen 3. They try to differentiate the patient one-to-one in IVAS and angio guide and OCT guide, and they succeed the non-inferiority of OCT compared with IVAS guide, as I told you before. So we are expecting the OCT guided PCI become at least 2A recommendation. And this is an OCT in case with unstable acute coronary syndrome. You can identify the thrombus at the MLA site and plaque rupture a little bit proximal. This is a still frame. Longitudinal view can be identified similarly. Here is an MLA site. By angiography, we saw this should be the carpet region. However, the true plaque rupture is a little bit proximal. This plaque rupture make a flow disturbance and make a thrombus at the MLA site. So when you treat, even in ACS case, similar to this stable angina, you try to identify the distal difference first and then proximal difference. Then here you can identify more than 2 quadrant lipid plaque from 3 to 9 o'clock. Then we try to select a much stable portion, and then we put a stent, as I already explained. In case with ACS, if you use an OCT, you can identify plaque rupture nearly 60 to 70%, and plaque erosion in 25%, and residual might be the calcified nodule as shown in this slide. And almost all cases, you can identify the thrombus. Red thrombus demonstrate the protrusion mass with shadow, and white thrombus demonstrate the protrusion mass without shadow, and also we can identify the mixed thrombus. And further importance of OCT is some special condition. This is a case with a chest pain in 44 years female. Initially, we speculate vasospasm, but we cannot identify any abnormality by angiography. Then we did an IVAS. IVAS demonstrated some dissection, but we cannot obtain a clear condition. Then we did an OCT. Here is a true lumen, and this is a false lumen. Fiber is ideally in true lumen in the distal portion. However, this comes to the false lumen and then true lumen. If we put a stent here, we close the true lumen. Then we try to get a true lumen using a different wire. Here is a different wire. The different new wire is in the true lumen here, right? And then we can put a stent because the patient is unstable condition. This is a still frame explanation. Okay, I try to skip here. And after putting a stent, we can get a bigger true lumen area and smaller false lumen area. There are still some false lumen, but it will disappear short after follow-up. And this is a still frame explanation. And the advantage of OCT has been already published in literature from the Spanish group. And the incidence of spontaneous coronary artery dissection is depend on the diagnostic technique. Angiography underestimate, and the OCT is the best to identify the SCAD. However, you have to pay attention to the increase of the dissection, similar to angiography if you use an OCT. This is another case. This is a very severe calcified lesion after CABG, and patient have a new disease. You can identify the significant calcification from proximal to the distal RCA. And Dr. Colombo demonstrated very wonderful example of the rotablator in similar case. And this is an IBUS. IBUS can identify the calcium. However, we cannot identify the behind the calcium because of the shadow. But OCT can clearly demonstrate the thickness of the calcium as shown in this slide. Distal portion identify the calcified nodule and 360-degree calcium in the mid portion and the proximal portion. At that time, we tried to use the rotablator for the lesion modification before putting a stent, right? And here is after rotablator, you can easily identify the aberration portion, and you can select the bar size based on these data. And if the thickness of the calcium is less than 500 micron, you can make a crack using a higher pressure as shown in this slide. And if you succeed to make a crack, you can put a stent and better result. This is a result. If you succeed to make a calcium fracture, you can get a bigger minimum stent area and a good stent expansion index, and it makes lower binary stenosis and lower target region revascularization as shown in this slide. So the cutoff value of the thickness of calcium to make a crack might be 500 micron by ROC analysis as shown in this slide. And so the PCI for bifurcation region is also the very important. Bifurcation region PCI might be 15 to 20% in all daily clinical practice, and the higher risk for complications such as branch occlusion, stent thrombosis, restenosis has been reported more frequently, as you know very well. And we cannot select the position of link. However, if there are no link at the side of side branch orifice, it is very good. However, if you identify the link, the result is a little bit poor. Recent advantage of OCT clearly demonstrate 3D reconstruction of the stent strut and wire position as shown in this slide. And this is one of the case of link-free type. There are no link at the orifice, and the wire is distal cell, and you dilate by kissing balloon, you can get an optimal result. However, if there are some link as shown in the green circle, if you dilate, you still have lots of stent strut at the orifice of the side branch, and this is a suboptimal result as shown in this slide. So if you use a 3D reconstruction in daily clinical practice, rewiring can be expected nearly 30% cases again, and this is one of the Japanese registry, 150 bifurcation region. We identify the link-free time and link connection type, and the result is optimal, nearly half. I agree, okay. I will finish soon. And suboptimal results demonstrate a higher jailed strut volume as shown in this slide. We failed to demonstrate the clinical importance, but link connection demonstrate the branch jailed strut volume as shown in this slide, and guide wire position and angle. And here there are tendency of incident restenosis significantly higher in suboptimal, but we failed to demonstrate the statistically significance because of the lower number of the application. I tried to skip the instant restenosis because previous doctor already demonstrated. So this is my take-home message. Similar to IBUS, OCT-guided PCI should be useful to improve the result of PCI and clinical outcomes, and at least Class A recommendation might be expected in OCT-guided PCI in the near future, although there are several advantages and disadvantages in IBUS and OCT. OCT can replace IBUS in almost all cases in daily clinical, except for the several specific conditions such as left main or RC orifice, or CTO or CKD and so on. OCT may have advantage in PCI for ACS, instant restenosis, several calcified lesions, and 3D reconstruction may improve bifurcation lesion stenting. Thank you very much for your kind attention.
So I think that was a wonderful overview and how to use OCT. I think in the interest of time, we're probably going to stop this session, take a quick 10-minute break, and come back with the afternoon sessions after that. Thank you.
I think we'll all break for a quick lunch, and within 15 minutes we'll try to reassemble back by 1:45 here so that we can save some time. I request all of you to have a quick lunch and assemble back in 15 minutes. Thank you.